So good afternoon, everybody. Thanks for being here. I know that it's late and it's been an intense day, so I promise this is not going to last an hour. So as Lorenzo said, I will present you my lecture today. I will present you the results of the studies that, together with my colleague at the University of Turin and colleagues from other institutions, we have carried out to address this research question. So why we have decided to focus on this topic? First of all, the reason is that, first of all, we know that socioeconomic inequalities in health exist and are relevant, and it has been consistently, these have been consistently observed for different outcomes across different age ranges, both in low, middle, and high-income countries. And it has been observed that subjects exposed to these disadvantages early in life not only have short-term effect, but might also have effect that lasts for the life course. So this is why it's really important to measure the socioeconomic position since the first year of life. The other reason is that we are involved in the birth cohort research field. And as you probably know, this type of study follow participants from their fetal life, recruiting mother either during pregnancy or at time of birth, collecting several information, both individual and household variables, and including social factors. And this is why this type of studies are ideally suited to measure the child's socioeconomic position. So we address this topic using different epidemiological and statistical approaches, from association studies to microsimulation modeling, systematic reviews, and we did it carrying out studies in the Italian setting, but also including data from other data from studies carried out in other countries in Europe. So I will briefly introduce you the child SEP indicators focusing on income, describing you a recent an income indicator that we have recently developed, and then I will show you the results of studies aimed at evaluating the association between family income and the early life child exposure pattern and health conditions. And the last part of my talk will be about studies that we have carried out to evaluate the potential impact of fiscal policies and income support intervention on child health. The conceptual framework is this one. So socioeconomic position that, as we have said, can be measured, as I will say in a second, can be measured in different way, affects, so subjects with a low socioeconomic position have different exposure to risk factor, both parenting attitudes, behavior, living conditions, psychological factor, environmental variables. We used to call this multitude of different exposure a subject can be exposed from his fetal life on loan, the exposome. So, and the subject with low income might also have a different susceptibility to this risk factor, because maybe low SEP children or subjects are also more likely of living in household with single parenting, with parents with diseases, or more exposed to financial shocks. And these lead to child health condition and then adult life. And we might also consider different further stratification factor, in particular the welfare system of the country where the study is conducted is, of course, relevant. So child SEP indicators. The indicators that are usually available in birth cohort studies are parental education, parental occupation, and family income. And although at least the first two are usually available in this type of study, maternal education is often used as the only proxy of child socioeconomic position because it is easy to measure, stable over time. But each single indicator captures a different dimension of this concept of socioeconomic position. In particular, we can think about parental education as a measure of intellectual resources, parental occupation as a measure of social prestige and access to economic resources, and family income is a direct measure of material resources and therefore is really relevant in terms of child SEP. It is relevant, but measuring the total disposable household income in birth cohort studies is difficult. It's difficult for several reasons. First of all, this might be a sensitive matter. So we might have an issue of missing values. Then we have, if we want to measure the total disposable household income, the person who is in charge of filling in the questionnaire or interview should be able of reporting about the income of all the household members, which might not be easy. So we might have an issue of measurement error, and measurement error might also arise because we have to consider not only the salary income, which might be the easiest one. We all know more or less our salary income, but non-salary income might be more difficult to report. And also, we have to take account taxes, because if you want the total disposable household income, in some way, we have to consider take out the taxes. So, and for this reason, there is also an issue of comparability across studies, especially if conducted among different countries. This is why within the Life Cycle, Horizon 2020 Life Cycle project, which is a project that brings together most of the European birth cohort studies, we have decided to develop an income indicator, which we have called the Equivalized Household Income Indicator. It measures the total disposable household income equivalized for household size and composition. So it takes account of the number of members in the household and their age. It is now available in approximately 20 European studies. European because it is measured using, of course, the data of the study, but also external data from a European survey, a pan-European survey that is conducted annually in a standardized way in all the European countries, collecting information both at individual and household level, including several measures of income, and one of these is the total disposable household income. How it works, we have first selected among these characteristics collecting the EHII, it's called, sorry, I forgot to say that it's called European Union Statistics on Income and Living Condition, EHII. So in this survey, there are several characteristics. We have identified those that we think are potential predictor of income, and these are listed here, both at individual level and the household level. And how it works, if we want to derive this indicator in a study, first of all, we identify which of these predictors are available in the studies, and then we use the country-specific EHII data. So if I have to derive this indicator for a study that is conducted in Denmark, I will use the Danish EHII survey data. I run the prediction model using the total disposable household income as the outcome and the predictors available in the study as the exposure factor. And then the coefficients derived from this prediction model are applied to the study data, and the equivalized household income indicator is derived for all the study participants. And in the studies for which this process has been conducted, the R, which is a measure of the prediction capability, range from 0.3 to 0.6. So we have, this is a graph showing the distribution of the predicted income in almost all the life cycle cohorts, which are, as I've said, carried out in different European countries. The orange dots represent like this one, represent the mean predicted monthly household income. And as we can see, the lowest income is observed in a Polish study and in the REA cohort, which is conducted in Greece, while the highest income is observed among the the northern study, the DNVC, which is the Danish birth cohort studies, and MOBA, which is conducted in Norway. We have validated the prediction model using a temporal validation, but after having derived this indicator for all these studies, we also wanted to evaluate the agreement between this variable and other SEP-related variables. So here, for example, I show you the agreement between the predicted income, categorized in quintiles. So 0 is the lowest the poorest subject, and 4 are the richest. In comparison with the two variables that were available in a French birth cohort called Eden, because in this cohort, the self-reported income was available, so the one collected through the questionnaire. And also they have this bank overdraft frequency. And as we can see, the agreement is quite good, because, for example, 70% of subjects predicted to be among the richest one reported to have a monthly income above 3,000, while the same proportion among those predicted to be in the lowest quintile is less than 5%. And we also observe quite a good agreement with the bank overdraft frequency. We derived this indicator in several birth cohort studies, as I've said, but we also derived it for a Finnish survey conducting on approximately 185,000 children aged between 2 and 17 years. This has been done within the framework of the Horizon 2020 STOP project. And in this survey, they had the possibility to link the data with registry information, including in these registries, there was the total disposable income variable. So we had the possibility to compare the registry-based variable with our predicted income. And what we did here is that we compared the distribution. We divided the variable in deciles, and we compared the range of the two variables in the two in these deciles. And as we can see, the prediction is quite good in almost all the deciles, apart from details, when it is expected the prediction to be less good. And when we regress this predicted income over the registry-based income, we observed a regression coefficient of 1.08, so quite close to 1, which means perfect agreement. So after having developed this indicator and derived it for these studies and checked that it was behaving well, we used it to study the association between family income and the early life exposure pattern of the children, using data from different studies in different countries. The exposome domain that were available for our analysis are the urban environment, so air pollution levels, built environment, natural spaces, meteoclimatic factors, lifestyle characteristics, so outdoor patterns, sleep, screen, behavioral pattern, exposure to passive smoking, to pets, and diet factors, so breastfeeding during infancy, and food groups, nutrients during the preschool age period. So we consider the exposome during the first 4 years of life. And we conducted the analysis first on the Turin participant of the NYMPHEA study only, and then we extended this analysis to several other cities all over Europe. And in order to evaluate the association between the income, so our predicted income, and the exposome, we used an approach that we call driver exposome-wide association study, where the driver is our income indicator, and the outcome are all our exposome variables. So we fit as many regression modeling as many exposome variables we have. These are the results for the NINFEA children participants. This is a volcano plot, so on the x-axis we have the effect estimates. We have dichotomized the income indicator as low, medium income versus high income, so the reference is the high income. And here we have the log p-value. And we have on the left side of the graph of this plot, we have those variables for which we observed a direct association. So the lower the income, the lower the level of these X boson variables, while here we have the inverse association. So what we observed that low-income subjects have lower level of fruit, grain, vegetable, and eggs consumption, lower level of walkability, transport, facility density, also lower level of NO2, which is a measure of air pollution, but higher level of land use diversity index. We then extended, as I've said, this analysis to other 10 cities, 3 from Spain, 2 from France, then Rotterdam, Copenhagen, Bristol and Bradford from UK, and Oslo in Norway. And what we found, we found quite consistent results for what concerned the lifestyle and diet domain. In most of the city, we observed that low-income subjects were more exposed to pets, passive smoking, screen exposure, and they were less exposed to breastfeeding, and in all studies, they were exposed to an unhealthy diet pattern, while the results on the urban environment were more heterogeneous. Although we observed in 5 cities that low-income subjects were less exposed to air pollution. So, from these studies, we concluded, first of all, although it might be given for granted, it is important to highlight that we confirmed that socioeconomic inequalities in the X boson pattern arises from really the first year of life. In NINFEA, we observed that children with lower income are less exposed to an urbanization factor, but more exposed to unhealthy lifestyle and diet. And these results on lifestyle and diet was also observed in the other countries. The results on urban environment are more heterogeneous, as these might be due to context-dependent urbanization factors that might be different in the different area we analyzed. We then move on and study the association of family income with child health. And we did it using different approaches. We ran association study to study the impact of family income at birth with different outcomes in different setting countries. We then developed a microsimulation model to study the impact of fiscal policies on child health outcome, and we conducted a systematic review to evaluate the impact of income support intervention on different child health conditions in high-income countries. So the first association studies was conducted using the NINFEA data, so about 5,000 singletons registered into the study before the 36th week of gestation, and we studied the association of maternal education and our income indicator with both low birth weight and preterm delivery. And what we observed, in the bottom part of this table, we have our household income, which was categorized in 3 levels with high income as the reference. And what we observed is that subjects with a low income had an increased odds ratio of preterm birth and even more increase for low birth weight. There was also an increase with maternal education, but the effect size were smaller. We then studied the effect of the EHII, the income indicator, on child BMI at 2 and 4 years, using data from 4 birth cohorts, 2 from Italy and 2 from France. And so in the bottom part, we have the results for the BMI at 2 years. Sorry, in the top part of the table, in the bottom part at 4 years. And here the A's was divided in quintiles with the poorest as the reference. And what we observe a trend in almost all the studies at 2 years, apart from NINFEA, with the higher the income, the lower the BMI. And these results were also observed in all studies at 4 years. The last study, association study I will present is use the Finnish survey data I've mentioned before, the one where we have both the registry-based income and the predicted income, our income indicator. And in this study, we evaluated the association of this variable with children overweight and obesity. We calculated the odds ratio of overweight and obesity. Here, the income variable are divided in deciles with the poorest as the reference. And what we observe is that the higher the income, the lower the odds ratio of overweight and even lower for obesity, with effects which are stronger using the predicted income compared to the registry income. So these association studies let us show that socioeconomic inequalities in health were present for the different outcomes analyzed in the different setting. We observe low income were positively associated with both preterm delivery and low birth weight in the NINFEA data. In both the Italian and French study, we observe an inverse association of income with BMI. And in the Finnish data, we also observed that income was negatively associated with overweight and obesity. So, within the framework of the life cycle project, we also developed a microsimulation model to simulate the effect of alternative fiscal policies on the income at time of birth of the child, and forecast the impact of these changes in the income at birth on child health outcomes. We developed this model using Italy as the setting, the Italian country, and childhood BMI as the outcome of interest. We are currently extending these studies using on other countries, European countries. We have called this model the Microsimulation for Income and Child Health Outcomes, MICO, and is made of two main block steps. In the first one, we exploit a well-established tax benefit microsimulation model called Euromod, which is available for almost all the European countries, to simulate the effect of alternative fiscal policies on the income. And we, of course, choose the total disposable household income. In the second step, we related the income to the child health outcomes using our cohorts data. For Italy, we used the NINFEA data. So in NINFEA, we study the association of the family income using our predicted income as the indicator on the child health of interest, so childhood BMI in this example. And we combine these effect size with the changes observed using the Euromode microsimulation. And with the microsimulation approach, we therefore forecast the impact of the fiscal intervention on the child outcomes. These are the fiscal interventions that we decided to study. We decided to evaluate the impact of these four alternative policies. The first one that we consider is a universal one. We simulated to give 100 euros either annually or monthly to all the household members. In the second one, we simulated to give again 100 euros, but to all the household members, but only the eligible household were only those with a per capita income below 500 euro. We use this is called the poverty reduction intervention. The third one is the newborn benefit, and we again selected only the household with a per capita income below 500 euros, and we simulated to give 500 euros either annually or monthly for each child less than 1 year present in the household. And the fourth one is equal to the third one, but we for each child less than 5 years. We evaluated the impact of this intervention in comparison with the baseline scenario. The baseline scenario means the actual fiscal system of the country in which we are studying, in this case, Italy. We compare the absolute effect, but we also take into account the cost of the policy, because, of course, this policies, 4 different policies have different costs. So here I show you the effect, the overall effect, without taking into account the cost. So here we have the prevalence ratio of the different fiscal intervention in comparison with the actual fiscal system. For each intervention, we have the annual or monthly, so I say that we gave 100 euros either annually or monthly for the first 2, and 500 euros either annually or monthly in the last 2. And I'll show you the results of overweight and obesity at 4 years and 10 years. And what we observe that there is a reduction of both overweight and even more obesity. These reductions are stronger at 10 years compared to 4 years. And the strongest one we are observed for the basic income and even more for the childbirth benefit, but also for the poverty reduction. However, even if these effect sites are more or less similar, the cost is very different. Here I'll show you the estimated cost in billions of euros for 1% prevalence reduction in overweight and obesity. Here I have 4 years, also 7 years and 10 years. And as we can see, the basic income, let's focus on the 10 years, so the bottom part of the table. The basic income is quite expensive, much more expensive than the poverty reduction and even more of the child benefit intervention. So fiscal policies can have an impact on childhood health. In Italy, we observed that both the universal benefit and the targeted interventions reduced childhood overweight and obesity, can reduce childhood overweight and obesity, but the costs are different, and focalized interventions are much less expensive, and therefore focalized interventions that increase family income, especially in the most vulnerable population, can help to prevent child overweight and obesity. The last study, I promise, I will talk you about is the systematic review that, again, we conducted within the framework of the Life Cycle project with the aim of quantifying the impact of income support strategies delivered during the first 1,000 days of life, which means fetal life and infancy, on different child outcomes, cardiometabolic, respiratory, and mental health. This was conducted in high-income countries, and we included in these systematic reviews only randomized controlled trial and quasi-experimental studies were eligible to be included in this review. What we mean with income support strategies, these are all the measures that taken by the government to provide an adequate income to the citizenship through different schemes, either social protection schemes, taxation policies and benefits, welfare to work interventions, minimum wage. What we found 18 studies, so not many, and most of them were conducted in the United States and Canada. So only 2 studies included data from UK and Scotland. In the black dot is for the studies where birth weight was the outcome of interest, while the red dot is mental health, the outcome of interest. These were the only 2 type of outcomes that we found. So no other outcomes were in the study that were eligible to be included in this review were observed. And the majority were quasi-experimental studies, but these are also these are all randomized controlled trials. This slide shows you the impact of the interventions by outcome. So we observe for the studies that had birth weight as the outcome of interest, most of them show a positive effect, so the effect in the expected direction. The intervention improved the outcome. While for mental health, results were more heterogeneous, with 2 studies showing a positive effect, 1 a negative effect, and 3 a null effect. This slide shows the impact by study design and intervention, and what we see is that the randomized controlled trial study show either no effect or negative effect. However, unfortunately, as you might have noticed, there is really little overlap between type of studies, outcome type, and intervention. So it was not really possible with this review to demonstrate an effect of the income support strategies in the first 1,000 of days on child health. However, we found consistent positive effect for birth weight, weaker evidence for mental health, but most of all, there was really lack of studies in the European setting and lack of studies on other health outcomes. I haven't shown you, but the effect size were typically small. However, at the population level, public health impact can still be large. So this is my last slide. All these studies show us that the association between lower income and poor child health is strong and consistent across countries, type of outcomes, and ages and time. Although we have not conducted formal causal inference studies, we believe that if child health inequalities are to be reduced, income support strategies should be part of a standard package of prevention for vulnerable households. So thank you for not running off to dinner before the end of my talk, and thank you to all my colleagues that carry out these studies together with me.